Okay, thank you so much for having me here. I really appreciate the opportunity to present this topic, which is dear to my heart. Um, I'm a doctor from New Zealand, family medicine practitioner. I also lived at a cult which is fairly notorious in New Zealand called Centre Point, which closed in 2000. I lived there for a short time as a child. After well, 10 years ago, I founded a project called the Centre Point Restoration Project, which was about child survivors of the community and trying to bring attention to what happened to them there and asking really for a restorative arc in that story for the harms that happened to them. I'm also the co-lead of a new collective called the Decult Collective, which came out of the Decult conference that happened at the end of last year, which is a group of professionals working in New Zealand and Australia who are wanting to work together informally to bring about increased awareness, advocacy, increased skills, particularly amongst the professional network. Also run a podcast called Cult Chat Podcast, if you ever want to listen. It's the only one of its kind in New Zealand, talking about cults. And most importantly for this talk, I'm also Senior Clinical Editor for Community, Canterbury and West Coast Health Pathways. And I'll tell you more about that as we go. So the talk, I'm going to cover a little bit about New Zealand and cults recently targeted, some clinical perspectives from clinicians I know who work closely with some cults in New Zealand, a little bit about a health system in New Zealand and this website platform called Health Pathways I work for. We'll talk about a suite of pathways or a platform or guidance that I've written for New Zealand doctors and nurses about people who are in cults or out of cults. I'm going to talk a bit about the contributors, give you an overview of it, talk about utilisation, and then what next. So, what is my goal? Okay, it's quite big. I want to mobilise the New Zealand health workforce to intervene in the care of cult-impacted people and to create allies for change. So, not that, it's fairly big actually. The challenge is much of the health workforce knows as little about cults as the general population and may fail to recognise the presentation and can contribute to harms through their ignorance and bias. So education is what falls into that gap. So New Zealand's a small country in the south. There's similar side to Finland and the state of Victoria in population, Victoria, Australia. We're pretty secular. Christianity came over with the settlers, and while it's not a country that values religion highly, Christianity does form the basis of New Zealand cultural values and worldviews. It's a fairly liberal society, values tolerance, personal autonomy, Kiwi ingenuity, and while the Indigenous people, the Māori people, more value community, collectivism, and family relationships. It's geographically isolated at the bottom of the world, and it's quite groundbreaking in some ways and liberal in some ways when it comes to cultic harm and cultic harm awareness. We're decades behind other countries in our understanding of its impacts, the injuries it causes, the prevalence in our communities. We've got few to no systems to prevent it and very little supports for survivors. So it's a pretty blank slate in New Zealand. In the 1980s and 1990s, we had Centre Point. This is the community, and Bert was the guru. And these are my foster parents. That's my foster father, and Casey, I'm not sure, she's in there somewhere. This is a psychotherapy cult I was connected to as a kid. It was all over the news in the 1980s, and particularly because it was weird, then because it was scandalous, then because it was worrying, and then because it was criminal, with child sex and drugs convictions for its leaders and a number of his close mates. And that was in the early 1990s that came to light. Despite of a lot of attention over 2 decades, Centre Point only closed down in 2000 because of the concerted activism of a group of survivors through the 1990s. After fighting tooth and nail, they managed to separate Centre Point from its charitable trust. When they lost access to the money, it crumbled. After Centrepoint closed down, another very interesting group became more obvious to the New Zealand public, though it had been operating all through that time as well. Gloria Vale's that cult, you may have heard of it. It's on the other end of the country, opposite to, there's a big row of mountains in between Christchurch and Greymouth, which is where it's nearby. It's about 4 to 5 hours drive from where I live. It's a deeply conservative Christian cult. It's highly patriarchal, very closed, practices very tight shunning. It's cut off from the rest of the world very much so. It's into its 4th or 5th generation now. As Centrepoint's sun was starting to set, Gloria Vale's sun was starting to rise, with increasing abuses coming to light over the last 10 to 15 years. Breaches of employment law, physical and sexual assault, failure to provide adequate schooling for the children, to name a few. It seems that no one had really grappled with the fact that it was the same thing as Centrepoint had been decades before. It was just dressed up in different clothing. Actually, they wore clothes, we didn't. Politicians, ministers, and their political parties looked the other way as a small band of activists, mostly survivors, some who were just caring members of the local community where they ended up, working with the media, brought human rights and the criminal abuses to the attention of the nation. So Gloria Vale continues to operate as more and more abuses come to light, while the government does very little. The shock of the nation felt in the 1990s over Centrepoint, and the crimes which happened there are being repeated in the 2020s over Gloria Vale. Same shock, no learning. Nothing changed in the national psyche, nor in the institutional systems in the 30 years between Centrepoint's downward spiral and Gloria Vale's rise. Even with Centrepoint's history of child sexual abuse convictions, the fraud, the charitable trust crimes, drug offences, no. When Gloria Vale's star started to rise, it was like the nation was completely naive to culture calm. This is a small country, and the impacts of both of these groups reached the consciousness of most New Zealanders at some point. Sadly, despite the attention they both received, New Zealand learnt nothing about cults. Centrepoint and Gloria Vale were viewed as separate, isolated, and unrelated, distinctly different problems which could be solved if someone would just close them down. In the sectors which interfaced with these cults, health, education, judicial, social sector, still knew nothing about cults. Despite media attention and plenty of survivor stories, it remains the case that health professionals and therapists are not taught anything about cults or group-based quiz control in their education and training or institutions in an ongoing professional development in New Zealand. As a health practitioner and a survivor myself, this is unacceptable to me. In 2020, there was one bit of research that was done, which was presented here, I don't know how long ago. Yeah, a while back, about Centrepoint and the children of that community. And there's one quote that I keep on using because it really stirs me. During the years of Centrepoint's existence, there was an alarming lack of action from health professionals and others who may well have known or suspected the abuse that occurred there. It's important that there is a broad knowledge of potential for this kind of experiment in communal living to go badly wrong, for those on the outside to recognise the warning signs. So I've been talking to some of my colleagues. In a series of informal interviews over a couple of years, I was able to draw out some of the issues from clinicians working closely with cult members and leaders in New Zealand. So Dr. C, who's someone who works quite closely in a high control group in New Zealand, because there's a number, noted to me that in this group that few clinicians knew anything in the area about high control groups nor how to interact with members while still providing ethical health care. That was the first clinician I talked to who gave me some idea how doctors might see people in cults, which was something I couldn't see because I knew too much about it. So that led me on to talking to other doctors, and Dr. M and Dr. L. The reason I've got these names is because I need to protect them and their relationship with the communities they work with. And unfortunately, it's very real. Dr. L and Dr. M are two doctors who regularly see cult members in their clinical practice. They noted when they spoke to me that these patients often did not come to see doctors in general practice or in the hospital setting. They had to go to them. During, in both cases, an outbreak of quite a severe infection that's usually quite preventable and we don't actually see in general practice anymore. It's vaccine preventable. Dr. L noticed that the decisions about healthcare that were made in this community about the outbreak of this infectious and rare, they've seen normally in general practice, illness, were made by the community leaders, not by the parents of the exposed or the sick children. In the high control community that Dr. L was treating patients from, leaders discouraged vaccination and antibiotic prophylaxis for those who were exposed contacts. While giving the close living arrangements of these members in this group, it was a big problem for disease control not to take any medical treatment. When reflecting on the challenge of providing evidence-based best practice to these patients, Dr. M said, it's a fine line between keeping engagement and creating alienation. Dr. L observed that sometimes while the child was in hospital for a serious illness or infective illness, the parents made quite different decisions for their children. He told me the conversation about vaccination was entirely different if the parent was on their own. There were a few that we did get consent from to give the right treatments to when the mum had an opportunity to decide. In his time working with the population that Dr. L was involved with, he noticed a fatalistic attitude towards birth injury and severe illness from cult parents, and that they weighed up information they were given in quite a different way from parents of other patients not in the cult. He said that he grappled with the task of trying to take fear away from the patient and not knowing how to do it. Dr. M noticed the prevalence of somatizing, highlighting its important diagnostically in an environment where real disease is minimized. He said, somatization is important. It can masquerade as organic illness, but it's also the flag of mental illness. He highlighted that the clinicians need to be self-aware of their own prejudices when working with people still actively involved in the cult. He observed that the expectation for women to get pregnant repeatedly and to avoid contraception entirely at times led to fatalities or to near fatalities for mothers who had health conditions which made pregnancy very unsafe for themselves and their unborn babies, requiring high-level intervention and hospital level care to avoid their deaths. Yet, despite this, the woman would become pregnant again and require the same level of hospital intervention again. Sometimes, and also noting this and how to prevent this, sometimes the doctors needed to be very creative in how they presented a medical option in order to support good medical care, to circumvent the rules and to give the patient a morally acceptable choice that they can make in their own best interests. Nurse T described how clinicians have felt hamstrung to act in the best interest of their patients. She described how they can fail to intervene for the good of the individual patients to avoid conflict with the leadership, thereby sacrificing the good of the individual patient to maintain their access to the community. She described how cult members would need to jump through multiple hoops to get access to the visiting doctor, may be declined a doctor's visit if the member lacked the favour of their supervisor in the group. She also described how women needed permission from their husbands or their fathers to get medical treatment. Even in emergency situations like during labour and delivery, women would need permission for intervention, or in life and death situations like cancer, the husband would decide what the right treatment for his wife was. In the cult, there was a huge mistrust of conventional medicine, which created a narrative that if there's another way of doing health care, then the person should choose that. Just a reminder, this is a Western country, like America, like Canada, high level of interventions. It's not Kapuni. Dr. D reflected that as a doctor, he has unwritten rules placed around his practice by the cult that his patient belongs to. When reflecting on what care he was allowed to provide, to deliver, he noted that it slowly changes your practice. It's easy to stop doing the basics of primary care like contraception and immunisation. He went on to tell me there's a lack of visibility for healthcare providers about how everything in the community is controlled. And describing his visits to the commune-based clinic, there is a feeling that the walls can hear. Dr. S noted that women do badly in the cult that his patients belong to, and he asked himself when considering if he should intervene, at what point do I broach the issue? He was aware that a text or an email might get read by others as the cult was using technology to keep surveillance on members. Male cult members had a contemptuous attitude towards the female staff in the practice, making it difficult for staff when they came to the practice. It's a red flag for relationship safety, he said. The way the female staff are treated makes me wonder what's happening at home. He's become aware over time of particular health conditions that the cult members are more at risk of, but this took many years of noticing patterns in the group. And with this group, he's now more likely to screen for health conditions differently. Despite decades of experience, Dr. S was filled with questions about how to best navigate the coercion in order to provide the best care for his patients. When people are leaving or thinking of leaving, how do you broach the topic? How can I tell? Is my instinct right? If I raise this, I risk the relationship. If I offer assistance and they're not ready, I'll damage the relationship. What are the signals that tell me I need to address this head on? So this is the bit that I wrote, but I'll go on to explain what it is. So, hang on. Okay, despite Gloriavale residents regularly visiting doctors on the outside of Gloriavale and in more and less, so over the mountains and the other side, a neighbouring region, that doctors on the west coast, our neighbouring region where Gloriavale is, were not really understanding them or their needs. So they've been there 60 years or so, 50, 60 years. It seemed that many of the doctors on the west coast knew as little about Gloriavale and cults in general as the general population. This apparent knowledge gap for doctors in the area was highlighting the need for targeted education, and I was in a position to do something about that. The New Zealand health system is funded by the government, with patients able to access the majority of their healthcare needs in hospital or specialist care through a funded free to the patient service. Primary care or community-based care is where I work, is partially funded, with patients paying co-payments to see their doctor and the health subsidising the rest, with subsidies being more available to those with greater financial hardship. So that's how our model works. As a result, most people in New Zealand are able to access primary care, and if they need hospital level care, that's free. So we have a thing in New Zealand called Health Pathways, which is where I've been working since 2012. I've been working as a clinical leader in my region, and that sort of expands to influence in the West Coast region where Gloriavale is situated. I work for a program called Health Pathways. That's the logo. That big map of New Zealand is all the different regions of health pathways, and I'm in charge of the maroon bit in the middle of the bottom island, Canterbury and the West Coast. This tells you a little bit about the users. There's a number of GPs and the specialists who use it and feedback. This is how many page views we had last year, I think. This is where it is all over the world, also in Canada, just saying. That's old, that's about 2 years old, that map. It's an online communication and resource tool. It's a roadmap for the integration of community and hospital-based care. It's written by clinicians for clinicians, used in everyday practice. A GP like me will probably be on it, off it, constantly all throughout a day. Chest pain. Oh, what do I do again? Angina. Oh, asthma. Flip, knee sprain. Oh, colds. So that's how we use it. And it's just moved into Canada last year. So I recently expanded to the West Coast where Gloriavale is. So the development of an education package for doctors began in 2023 because I went, damn it, opportunity. There was very limited published research on the prevalence and the impacts of cults in New Zealand, and few experts on the topic. Normally when we write a pathway, we go to the local cardiologist, and it's a condition we know about, we use all the time, so it's not very hard to write a pathway. This was really unique. No one knew anything about it. There were no experts, and normally I get support from experts, and I found out suddenly that I was the expert. So as such, I worked with a group of people to develop a package of pathways. I conducted multiple interviews with clinicians and survivors, applied my own knowledge of the topic along with my understanding of general practice healthcare delivery, how it works. I asked survivors about their experience in the healthcare system while in the cult and afterwards their experience in our health system. And from the clinicians, I asked them about their challenges, what they'd learned, their questions. I gathered the material into a working document, which became the basis for the pathways and further, So contributors, this was who I talked to. So that's 24 people. That's the specialty areas. Some of them had lived experience. All of them, bar the psychiatrists, had actual expertise in cults, or, no one's got expertise, let's be fair, experience. The psychiatrists were really important just because of the content. One of them was a child psychiatrist and one of them was an adult psychiatrist. Normally, when I write a pathway, I have one or two people I work with. So this is remarkable and different. Also asked for input from people internationally as well, which I got some input. So what about you? I'm going to talk about that. So looking at the actual pathways, look, there's probably about 10,000 words in this, and this is just a quick run through with some screenshots. There's 3 pathways. One to be used in a consultation with someone you've established is still in a group, one to use with, and these are used in your 15 minutes. So you click, you move on. You can't absorb much fast. So one's for with a person who you've established has left a group, someone you've established is still in the group, and then there's a pathway that's got thousands of words on it about background information, what is coercive control, yada, yada. So this is the resource page. And I've just opened up drop boxes I think you might find interesting. That's the closed one on that side, all of the headings. This is some of them opened up. So what is a high control group? That's the level we're talking about here. What's the difference between a born-in and a recruited? Like, they don't know that stuff. They don't know its relevance. So, this is something you'd read in your pajama time. That's what we talk about it. You're at home in bed in your pajamas and you haven't had time to do it at work. So it's pajama time work, this. This is this approach I developed in my own head, how you might deal with a person who's in a group. What do you need to think about in advance? You've got to prioritize trust building. Absolutely, utterly critical. You've got to think about continuity of care, so important. They don't want to tell the next person again, all the different family members and all the way they interact with each other. Trauma-informed lens, of course. Confidentiality, absolutely critical. You don't just text any old person the results of whatever test. Working out, is the person in the room safe? Are they an informant? Are they monitoring? Are they controlling? Talking about, depending on where they are in their relationship with the group, how do you talk about the group with them? How do you talk about your concern with them? Each of these blue things, there's another bunch of text in it, so I haven't opened it up. Respecting any health choices they make, even if it's an alternative health choice that you don't agree with, any decision that is in the best that they're making for themselves should be congratulated and encouraged. And how you talk to them about their beliefs, the whole idea of the neglect of healthcare. And this one, huge drop boxes in it. Obviously, I haven't opened them up, but they're just like, what might the clinicians see? They can't do an analysis of the group. They don't have the information. They don't know anything about coercive control in the group. They don't know anything about the group, but what they know is about the person in front of them. And the way I had to think about it was, what are the keys that the clinician might get? And frankly, I haven't come up with a perfect answer, not even close. And the good thing about Health Pathways is they are rolling and live document. Because I'm the editor of these, I can go back and go, oh, someone's told me about, a 3-question tester that a doctor could do to ask questions if they're in a high control group. Great, I'll put that in. So if anyone knows of anything, to determine quickly in 2 or 3 questions, if this person is in a highly controlling group, that could be added to the pathway as a wee supporter for that assessment. This is about the different aspects of harm that might happen. That's an open Dropbox again, so I'm not going to give you time to read it. Here's the other. This is now the full assessment of the clinical consultation group pathway that you might go through. So this Dropbox here is about being ready, and that's the problem, is you're never ready. You've got 15 minutes. You come in, the person reveals or they don't a highly complicated problem, and you're entirely unprepared. But sometimes you get preparation. Like you're told, you get a phone call from someone to say someone's about to leave a group and maybe I can do some reading or book a bit more time or get someone to sit in. So is moving in to look at some of the areas, some of the ways they might not be able to access healthcare and how that might affect the consultation with the patient. More again about this one here is about some of the factors you might need to consider that might suggest that the person is going to be at higher risk of harm, like they are standing up to people in the group, they're a child, they're elderly, they're LGBTQ plus. This one here is a Dropbox specifically about children and young people. Oh, yeah. This Dropbox here is about acutely unwell people who might be in the process of leaving the group or in the group and becoming like psychotic or suicidal because they were presenting to the local hospital and the clinicians didn't know how to make the assessment in that context. And it was really about highlighting the severity of the risk for people who are in a high control group. These Dropboxes up here have all got information about medical, dentistry, sexual, medical stuff that you might not think about because you don't realise that they haven't been done. Because normally you see people who have high access to healthcare, and of course abuse. So moving on, this one here I opened up here is about highlighting to the clinician that power is a key role in the interaction and you need to work to reduce that power difference. There's something here about focusing on long-term health care that may have been poorly managed, that you'll need to go back to the basics in many cases with some of these patients. Have they had their diabetes checked? You know, that hasn't never been checked. They haven't had the bloods they should have had done. Then there's a whole bit about somatization, which is that challenging issue of are they somatizing because there's no other way to express their distress, or are they actually group won't accept it? So it's coming out as real psychiatric illness. This is about the basic fundamentals of learning to look after your body and your mind, which get drip fed to you throughout a relationship with a doctor over your life. And if you've never been able to see a doctor, you might not know about things like safe sex or getting immunized or, you know, all those sort of basic looking after yourself ideas. This one here is about ways that you can actually offer support. So we've in one of these Dropboxes, we have a page of therapists who are willing to see people who in this area. It needs to be updated because a lot's changed in the last 12 months since I wrote it. But the idea being that clinicians could actually tell people, go see this person, they know about cults. In the box here, there's a link to a page of resources that people can print out, the GP can print out and give to the patient. Read this book, listen to this podcast, go to this website. And here's a list of therapy, peer support groups. Again, it probably needs to be updated because there's some other ones that have popped up since I wrote the page. The members page is really similar to the leavers page, except there's a few distinct differences. There's a few wording changes and things like this about actually like how do you talk about the possibility of wanting to leave? How do you support them if they are wanting to leave? And how do you get them support? You're not going to put them in a peer support group, right? But you might encourage them to talk to someone who's left and help them to form a relationship. Now, the big issue here that I haven't mentioned is the whole, how do you determine a person's relationship with the group? And I change, I think it was mentioned in another talk that I see all the time and doctors are very familiar with about smoking cessation. Are they pre-contemplated? Are they contemplated? Are they motivated are they on the way out? Are they moving out? And I think of this as being a bit like that, working out where the patient is in relationship to the group, and maybe they're going backwards and forwards in the cycle of change. Maybe they're actually going back into the group. Maybe they're moving backwards and forwards. And that's really important for the clinician to know how to even structure a consultation with them. But we're used to doing that because we deal with people interacting with a thing that's harming them all the time, whether it's smoking or alcohol or whatever. That's what we do. We're always moving people towards moving away from the thing that is hurting them. So this is where it is across the country. There's 10 regions, and Canterbury's my region, well, actually Canterbury West Coast. And it only went live in Canterbury 6 months ago, and the others have gone live slowly over time. These aren't really high numbers, but I think of these as being like a clinician for each number and maybe 10 patients for that clinician, so and it's early days yet, and we haven't done an education session about it yet. Oh, okay. So this is my question. Can the medical workforce become advocates and allies for cult impact people? And I think yes. So I've got a few things coming up over the next 6 to 12 months to sort of publicise these pathways and make them more apparent. And like I said, there hasn't yet been an education session about these pathways, which is going to be next month. And we'll see what kind of page numbers we have. But yeah, any questions?